Hello, and thank you so much for joining us today for the webinar, The Art of Perinatal and Infant Oral Health. It is a great pleasure to introduce to you Dr. Francisco Ramos-Gomez, whose aim during this presentation will be to train physicians, general dentists, dental providers and their team on how to prepare with a young child 0 to 3 years of age in their dental practice. Dr. Ramos-Gomez is a professor in the Division of Pediatric Dentistry and the director for the Pediatric Dentistry Preceptorship Program at the UCLA School of Dentistry, California, Los Angeles. He is a diplomat of the American Board of Pediatric Dentistry, a fellow of the American College of Dentists, a former member of the executive board of the American Association of Public Health Dentistry, and one of the first 2 dental mentors for the Robert Wood Johnson Harold Amos Medical Faculty Development Program. Dr. Ramos-Gomez has been a pediatric dentist for more than 20 years, with specific focus and research in the areas of early childhood caries, ECC prevention, oral disease risk assessment, and community health, with an emphasis on underserved populations. He has lectured in the US and many other countries around the world and had published numerous publications. I would like to thank Dr. Ramos-Gomez for being with us today and Colgate for making this lecture possible. Please take note of any questions and comments you have during the lecture, as they will be addressed by Dr. Ramos-Gomez at the end of the presentation. Without any further delay, please help me welcome the expert himself, Dr. Francisco Ramos-Gomez.
Thank you. Thank you to everyone. Good afternoon, good evening, good morning, wherever you are in the world. I really appreciate your time and effort that you're spending here with me for the next hours. So today we're going to discuss all the issues about the art of perinatal and infant oral care. And there's my email address. Please, if you have any questions or anything you need to discuss further, feel free to email me at any time. It would be great. I want to start with an ECC outline of the presentation so we can maybe walk you through some of the specific things we're going to be discussing. First, we're going to be talking about the whole issue of perinatal and early childhood caries. What does it mean? What are the issues on these specific areas? Then we're going to move to trends and characteristics of these specific issues. We're going to discuss then as a third theme, the Canberra risk assessment factors related to early childhood caries. We're going to discuss the 6 steps for infant oral health, so you guys have it very clear in your minds how you're going to set it up in your practice, hopefully this week, whenever you can get started, or if you're already started, to emphasize some of the things that we have already discussed. What is your role as oral health care providers, regardless if you're a pediatrician, a physician, a dentist, a dental provider, dental assistant, hygienist? All of you, you're welcome, because you all play a main and a key part for this team approach of integration of medical and dental. We're going to then discuss briefly about anticipatory guidance. What are the specific counseling steps we need to give the parents and ideas to start changing behavior and trigger really good oral behavioral change in their minds. And we're going to finish with some policy recommendations and implications. So with that, let's get started. I'm going to start from the 30,000 miles up in the sky view, sort of to give you an idea of the framework about some of the specific issues that deal with child and maternal health. And for example, this is a framework for women's and children's health that was designed by the World Health Organization. It's called the Partnership. It's a very exciting program. It was translated into the US as Life Course. Life Course is because based on the age of that individual at any given time, and based on the risk of any particular diseases, as well as the regional location, geographic location, and ethnic background they are, there will be some very specific areas, especially through pregnancy, birth, as well as here, when you have a dual participatory pair, where both as mother as a child will have to be in a very symbiotic situation, deal with their health issues, until they kind of separate or split up a little bit until the child is 6-7 years of age. So these are like some key, very specific areas that we need to really emphasize that women and their infants are much vulnerable for, specifically on oral health and oral disease. With that, we move into the framework that Susan Fisher Owens with the Can Do Center, we came out with the specific framework of disease in oral health in children's level of influences here, at a family level influences, and community level. So as you can tell, it's a very complex multifactorial disease that plays really a lot of interactions, and we really need to focus in a systems change approach. So with that in mind, we need to also assess the demographics of the population we're trying to reach. Here in the United States, we see a whole browning of America, where a lot of the demographics, the Hispanics, are growing in many of the states, as you can see here on the West Coast and the Midwest. It's really pretty much a uniform of demographic change affecting Hispanics and Latinos. Therefore, we need to put some of our attention and emphasis in underserved populations, especially minorities, women and children of color. African American, Native American, Latinos really play a major role for this changing of the demographics of the interventions we're trying to reach in a culturally and a competent, appropriate way. We created with Wendy Meridian a framework for more specifically on the areas of really putting the child at the center of our whole interventions. What are the kinds of things that are going to affect the child at the end of the day? The policy implication, the social environment, physical environment, culture, services, and policy, which really will play a big determinant on the child's chances to have better health, and an issue of equity and an issue of human rights for oral health care for all, especially for the young children. The California Dental Association and the Foundation specifically, they came out after the New York guidelines with some very specific guidelines of the evidence base for perinatal oral health. I want to bring this to your attention. They really discuss this whole issue of the myths of providers about providing dental care for pregnant women, to treat or not to treat. That should not be anymore a question about this. It is relevant and so important, and to really emphasize that untreated maternal tooth decay increases the risk for decay in their child. And if we cannot really come up with the evidence yet of this association with preterm labor and low birth weight, at least what is in unison, and we have over 30 years of research and evidence, is that there is a maternal and child transmission that we need to take very much into consideration for pregnant women and their children. But going back to perinatal health specifically, what are the issues that these women are kind of have at this stage in their lives? They have acid erosion, they have some immunocompromised status, pregnancy gingivitis, periodontal disease is very common. This whole issue of reduction of pain is essential. When these women are in pain, they self-medicate themselves usually if they cannot seek the appropriate care. So we have to take that into account. And what I mentioned earlier about transmissibility of the disease will be an essential part. But it's a beautiful time where we can establish good oral health for them and for their baby and their infant. And in the States, when we deal with insurance companies, this is in some specific areas they might have the only window of opportunity where these women might be covered or have some dental insurance. So basically, as we mentioned earlier, there is not a final association yet determined between preterm labor and low birth weight, but we know that several studies with Marjorie Jeffcoat and Offenbacher, they really relate still association of periodontal disease with some poor outcomes in these young children. But what this document and this report really help us out is that to demystify all the concerns of providers out there about dental x-rays and local anesthesia present, no additional fetal or maternal risk compared to no treatment for oral diseases. As I mentioned earlier, women do not seek or refer care by their doctors. They are concerned that their dentist might not see them. And there's a lot of fear still among providers about treating these women appropriately. And therefore, these women tend to medicate themselves. So the whole idea of this transmission, we know for many years, we have evidence of one thing, this child maternal transmission, and we need to really see these women and their babies in a participatory pair approach where the interventions have to be dual, and both for the adult, for the caregiver, and the women, as well as their infant and their baby. The consensus statements, and I recommend you go to the cdafoundation.org to get all the summary information about this specific policy and report, which is great, really come out with the the whole idea that good oral health and control of oral disease protects a woman's health and quality of life, and really setups that the whole framework that optimal oral health for pregnant women should be essential and should be our focus. And it discussed about this issue of this dual approach that we mentioned earlier, about how we can really maintain very specific treatments before delivery when possible, and we can really optimize the oral health for these women before their baby is now in life. And the recommendation of visit the dentist during pregnancy, assess the mother's caries status, perinatal status, and maybe use of some antibacterial recommendations for these young women, especially to reduce their levels of bacteria down so they do not pass the bacteria so early on to their children. We were delighted and we're so pleased that the American Academy of Pediatric Dentistry comes out now with some specific recommendations that every expectant mother receive a comprehensive oral health evaluation from a dentist, that radiographic assessment and treatment of oral conditions should be performed with attention to maternal and fetal safety and patient control, and parents and caregivers establish a dental home for infants by 12 months of age or the first birthday. So with that, I just give you a little synopsis and a summary of what are really the key issues of perinatal health that we need to take into consideration. Now we're moving into the overview of early childhood caries. What does it mean? What is it, the status of that in our country? It's the umbrella term that was defined by the Centers for Disease Control years ago for baby bottle tooth decay, nursing bottle caries, you name it, all of those terms affecting children's oral health below the age of 5. And it really highlights the issue of precavitated lesions as the first markers of disease progression, especially in these very young children, which is an essential part. Most of the reports and most of the data, epidemiological data that we have of caries in children really shows us when the tooth has already the holes in the molars or the caries is so obvious that they mark it as caries child. But they are pretty much very limited on the studies that we have on precavitated lesions, which are the first signs of disease progression in these very young children. This is some cases of severe early childhood caries where you see a distinctive pattern where usually the disease starts with the upper anterior incisors due to the milk or the liquids or the exposure of the foods, and it goes down to the first lower molars and rapidly progress as the tooth are erupting. So the older the child gets, the more decay will be getting, especially if they're having high levels of strep mutans and lactobacilli. It's considered by the Surgeon General report as the most prevalent chronic disease of childhood, 5 times more common than asthma, 7 times more common than hay fever. And yes, it is a problem in the global community. I can share with you some of the stories that we have from many countries around the world, especially coming from the IABR. We had a symposium in ECC where every continent, Africa, India, and China, in the US and in Europe, it's considered a global problem of an epidemic of ECC. And these are some of the regions, some of the data of the MFT. Again, most of these studies in most of the countries around the world start when the 6-year-old molars, they can be counted. And unfortunately, the lack of data for 0 to 5 is something that we need to really address and become advocates in our own ministers of health, in our countries, to really have a better perspective of the disease process in the different countries. And since I'm in California, I'm here at UCLA in Los Angeles, I have to address the issues of California. We had a very several studies since 2004, 2006, where it shows that a third of our preschoolers, that's around 54% of children under 5 years of age, will already have the disease. So almost 1 out of 3 will already get it by K3, or by their 3rd grade will have around 70% of the children, which is a huge epidemic, especially for our state. And we're trying to make a dent about really reducing the burden of disease in these populations. So who gets early childhood caries? It can happen in any family. It's associated with low socioeconomic status, but I can tell you a whole range of families now that they don't want fluoride exposure in the children, or they don't drink tap water, or they allowed a lot of sugar intake, within the households, they will have the same problem regardless. Some very specific ethnic and cultural groups are very much defined as the ones that have the majority of the burden of disease, especially the Latinos, the African Americans, as well as the Native American Indian children. It's more prevalent also with children with special needs or special with disabilities. Any child who has difficulty accessing dental care because of a complicated medical, physical, social, or psychological situation, and also competing needs. Some of these children might have to take medications every 2-3 hours that are full of glucose. So that's a huge characteristic. Drug-induced caries is very common in children that have to use sweetened medications on a regular basis, in patients with asthma, for example, that have inhalers or medications that will reduce their salivary flow, exacerbating then the whole issue of microbes and strep mutans and lactobacilli in their mouths, restricted diets, difficulty brushing, and many competitive needs that we need to address. So we need to flag these children and be very proactive in preventing these disease patterns very early on. In the U.S., in the States, the general broad cost of a full mouth rehab under general anesthesia, it's around $12,000 to $15,000 per child per case. This is outrageous for us to think about it, because also many studies are coming now with the data that shows Almeida, Tate, Edelman, that shows that over 54 or 60% of the cases after 18 months to 24 months after these cases are done, that children are coming back the same or worse off as before they were seen. Why? Because we never addressed the etiology, what caused the problem to begin with. And because these children are treated very aggressively, and the behaviors are not really taken into consideration, they will continue their patterns of disease progression. So this is what the data is showing that we're very distressed by, that you will think that by having all these full restorations in children will make a difference, but it's not. We must treat the infection and the cause of the disease to begin with. And this is the whole idea of the effects of ECC. We know it has huge repercussions in school readiness, in pain, infection, self-esteem. That children cannot go to school is the number one category, or the number one cause of removing or taking the child out of the school system because of a dental emergency or dental care. There's an inability to concentrate, impaired school readiness, can affect sleep and overall health and well-being. A lot of these children are misdiagnosed also with mild cases of autism or with attention deficit disorder, and the cause to begin with is because they have a nerve exposed, or their tooth is hurting so much that they will be jumping up and down the aisle. The failure to treat the infection can continue, and it will cause failure to thrive and delay growth patterns, has huge repercussions for the child, as well as self-esteem, with unattractive mouths and so forth. But the message that I really want to convey to all of you is that primary teeth are very, very important. They have to deal with eating and nutrition, holding the space, proper speech development. You have no idea how many mothers say, but Dr. Ramos, there's only baby teeth, who cares? And no, we say, it is so essential that you think about this is a continuum, right? Whatever happens in your primary teeth or your baby teeth, with any disease, it will continue through your mixed dentition and your permanent dentition as well. So we need to be advocates for primary teeth. It is essential we do that. And of course, the smiling piece that we need to think about. So what causes ECC and how we can prevent it? ECC is a chronic infectious transmissible disease. We know that mutant streptococci is associated, and there is also lactobacilli in there, and it happens through vertical and through horizontal transmission as well, which we need into consideration. For any of you that haven't seen, this is what strep mutants look like. They're colonies that form in the biofilm in the transparent layer of the tooth, forming the plaque. And we used to think that we had some sort of timing before these colonies will be starting in the mouth. But we know as soon as that child is born, and even before the eruption of the first tooth, guess what? These babies are having under the dorsum of their tongue, on on the cheeks, on the floor of the mouth. Already the colon is just waiting for the first tooth to show up and start colonizing them very early on. We know there is some genetic link. The amount of the percentage, it's really still undetermined, but we're now moving into the era of omics, genomics, proteomics, so we'll get to know more about this whole genetic link. And what we know for sure is the process of disease will continue with this bacteria causing some acid that will start demineralizing the enamel very early on. And these are the precavitated lesions or the white spot lesions that will start showing before the visible tooth decay is in the tooth. So it's something you need to be almost like detectives to check for these white spot lesions very early on. There's a lot of discussion about weaning the babies from the breast or from the bottle, that there are differences between breast and bottle feeding. And, we try to stay away about telling the mothers not to breastfeed their children at all, but we know that the AAP recommends using a cup at 6 months of age and consider weaning these babies after 12 to 14 months. But we really stay away from telling them when to stop breastfeeding. It's pretty much a woman's decision to do that. But what we really concentrate is in two main things. One is that to try to do their breastfeeding or bottle feeding not ad lib. That means that it's controlled, especially the night feeding. And after that they should wipe the baby's teeth with a wet cloth or with a special toothbrush or something, just to remove the plaque or remove the whatever debris of the milk is in there, whatever food has been left, to try to remove or try to keep those teeth cleaned up before that you put the child to bed at night. So this whole idea of using baby bottle or not at night is something that we need to really address, especially early on with the families. And these are the white spot lesions that I'm telling you about. I really want you to learn how to flip the lip, and wherever you are, to teach the parents how to look for them, community health workers, the Head Start teachers, anyone in the daycare centers. If they notice that the child, especially, it starts in the 4 anterior incisors, in the cervical areas, which is right in the neck of those teeth, you'll see those white spots, how they'll be there, starting this whole demineralization process. And the most important thing about this stage is that these lesions can be reversed back. And we see that routinely in our clinic, especially with our patients are seen and detected early on. Early intervention is really the essence of remineralize the lesions back and keep these healthy teeth healthier. So part of the interactive session for you is to have some questions. So I'm going to start with the first one. So this is for all of you. How soon should medical and dental providers will encourage parents to take their infants for a dental screening or an exam or risk assessment examination or a screening? Please let us know what your answers are. And I'm so proud of you that most of you are right on target. Excellent, right on target. That by age 1, that should be by the first birthday, you should be able to make sure that these children are assessed properly. And I'm going to tell you what, because this ECC can be prevented, yes. We have some very successful interventions for pregnant women and for mothers and infants, and especially targeting very young children. And we emphasize, like the American Academy of Pediatrics, the American Academy of Pediatric Dentistry, that the H1 visit or the first birthday is essential for a good risk assessment of these babies, a dental screening by the pediatrician or the physician or any pediatric qualified provider to ensure that these children do not continue on progression of disease. We wrote a very exciting paper that also you have it available at the CVA Foundation, where we show you all the protocols for early remineralization of the enamel and how to keep healthy teeth healthier, especially using our camera protocols that we're going to discuss later on today. There are 6 steps that now we recommend as part of the protocols for infant oral health. The AAPD has endorsed them, starting with risk assessment as step 1, and knee-to-knee positioning of the baby. Remember, these are protocols for 0 to 2.5 to 3-year-olds, where there is no dental chair available in the office. So, or you can do it there as well with a Toothbrush Prophy as third step. Then we're going to do a clinical child's exam or assessment, a fluoride varnish application. And then for me, which is really important and really key, the whole area of self-management goals and anticipatory guidance. So we're going to spend some time about motivation, interviewing, and engaging the parents appropriately. We have a very limited supply list of things that we will require, so you don't need much. So let's go briefly through the first step, interview and camera. We're going to ask all the questions to the parent. We are going to incorporate those hopefully in our paper record and our dental record as well. We're going to build a rapport with the parent and the caregiver. We're going to be engaging and asking questions to the parent, and use the staff to occupy child during the interview. You don't want any distractions. And we're going to show you a little clip about some of these interviews with one of our assistants there, and our nurse practitioner. She works with us. So she's asking some of the questions to the parents. They're engaging there with that child. Remember, in pediatric dentistry, you have a triangle. It's the provider, the baby, and the parent or the caregiver that you need to take into account for any of these interventions. And you need their attention. So there she is filling out our camera tool, our camera form, which I'm going to share with you what are the specific areas that we have. The whole risk assessment tool, it's been developed based on the Featherstone's model. Dr. Featherstone is the creator of the Caries balance model, where he mentions about the pathological factors in one side and all the protective factors in the other side. And we need to address those. We need to ensure that we have as many as protective factors in this child, in these babies, and in these patients at every single moment. This is our form. We're in the version 3.0. We're coming out with a new version. It's a work in progress. There's 3 main domains. If I want you to remember something, is that regardless whatever risk assessment tool you use, you need to think about 3 specific domains that your form needs to have. One is the risk factors, or the biological factors, which have all the questions here. And we took a lot of questions, and these are the ones correlated with, associated with disease progression. Then we have the second domain, which are the protective factors, and the third domain, which are the clinical findings. That's when you flip the lid, and you're going to see there's obvious white spot lesions in the mouth. We write which teeth number they are, and also if there's restorations present, we're going to be assessing those. But also look at our column. We are assessing new remineralization because we want to address if any of our interventions are working properly, and what we left the mothers to do at home, are they working on them? We're delighted that the American Academy of Pediatrics came out with their Canberra modified form. It's half a page. They send it out electronically with the same domains, the risk factors, the protective factors, and the clinical findings. And they show great, beautiful pictures, especially teaching physicians and pediatricians and any other healthcare providers about what the white spot lesions are about, what are the kinds of specific obvious decay, what are the kinds of things to look into the mouth to really create this whole idea of hopefully a dental referral by age 1, so a dental provider can assess these children more thoroughly. The whole idea of our risk assessment tool is to recognize that children at high risk or low risk, and how to keep them from a high to a low. And some of you are going to tell me, Dr. Ramos, all my patients are high risk. There's no need for me to do that. No, yes, you need to do it, because at every baseline you need to move them and hopefully assess them and move them from a high risk or extreme high risk to a lower category and keep them there. This is not stagnant. These risk factors might change and vary from day to day and patient to patient, so timing is an issue. You need to address those. The babies will be crying, especially when you do a knee-to-knee exam. We're starting very nicely with brushing the baby's teeth. Everything will be fine. They love it. They will cry, some of them. But we sing songs like AAPD while they're crying, and we keep the parents very comfortable so they don't get upset or anything. We're going to tell them their baby's going to cry because it's going to cry no matter what. They still don't have the sensorial changes, and don't plan to do any behavioral change in a 1-year-old or 2-year-old, because really nothing's going to work. Just make sure that you're very gentle with them and try to just teach them how to brush the child's teeth. I wish these babies will come with a manual of instructions. They don't. We are their manual of instructions. And we do a tell, show, do approach, as you can be able to see here. So we're teaching the mother how to brush the baby's teeth here, and we're going to go through some of the things. We tell them, we show them, and then we let them do it. You have no idea how many of them they tell me, Dr. Ramos, no one has ever taught me how to brush my child's teeth and to go into my child's mouth. So we show them how to brush. We sing a song in English or in Spanish, and we teach them how to brush the tongue. If you can see there, we tell them, look, how the tongue is full of a lot of bacteria, candida, all this white stuff in there. We need to remove. A lot of the parents were not aware they have to brush the child's teeth and their tongue as well. So this is an essential part of the whole discussion, and then we let them do it. They practice with us, and we let them see what happens. Question 2. Let's move to question 2. If the child is 2 years old, how much toothpaste should I use to brush his or her teeth? So let's see what you guys tell me. Okay, I think we have different answers. So yes, the good answer is the P, amount, size. We're going to discuss some of the latest recommendations based on this big evidence-based group. We need to encourage the daily use in the morning and before bed, a small pea size amount, that in the appropriate amount. It is essential that these children are exposed to toothpaste at a very early young age. It's very, very important. These are the new guidelines from the American Dental Association. They spend many years coming with this great report, and they come with a conclusion. I know the American Academy of Pediatrics and the AAPD as well, the American Academy of Pediatric Dentistry, are following suit, that a smear of toothpaste for children under 3 should be recommended. A smear amount is like a grain of rice. Is this little amount that you see here, because people might have different conceptions what a smear is about. And you can put it also where the blue and the bristles are, but it's just this teeny tiny amount that we know and we understand the children do not rinse, and they might swallow, and we want to avoid swallowing of the toothpaste. So little amounts, but yes, as soon as the first tooth is present, until 3 years of age, they should use the smear, and after 3 years of age, they should use the pea-size amount that is right there in the picture. So please make a note of it. This can make a huge difference. If there's one single tool and weapon we have, is the use of fluoridated toothpaste at a very young age, which is so essential and so important. Question number 3. How many times in a day do I have to brush my child's teeth, and for how long? So this is going to be interesting. So twice a day for 2. Oh my God, everyone seems to get it right. Yes, the Ad Council and many other corporations came out with this great campaign. You can Google it. I'm going to show you a little clip of one of the Ad Council's 2 minutes twice a day. It's 2 minutes times 2, and this is a little bit of what the video looks like for you guys to see it there. They use Sesame Street with them, and it's a great thing. And they have them in English, in Spanish, in different languages. And you can actually have a great, and it's age specific as well. Some of them have wrappers for older kids, and it's very age appropriate as well. So it's a great thing. You can download these videos and have them as apps. And it's a great resource for you to really encourage brushing 2 minutes twice a day. Very good. So moving along, the MCHB also has the recommendation of the use of the smear of fluoridated toothpaste, and it's important that we do on children under 2, cleaning the teeth at home. It's so important that the parents understand that they need to be the ones responsible of brushing their child's teeth until that child is 8 years old. Most of the parents are very surprised when we tell them that. They think that a 2-year-old brushes their teeth constantly. They say, well, they play with their toothbrush, but they need to be the ones responsible for the supervision at home, which is so important. Moving to step 4, now is the oral risk assessment, the oral clinical assessment, and the exam. Depending who you are, if you're a provider, a physician, you can do an oral assessment, but the dentist will do the dental exam. That's based on licensure issues in each state. But this is how the definite presence of thick plaque it is. Early indicators are the white spot lesions. So hopefully they will assess and everything, and we can be able to look and like hawks detect these white spot lesions throughout the teeth and the mouth, because those white spot lesions will become brown, and those brown lesions will become that heavy, severe early childhood caries that, they need. At this stage still, we can do something to reverse these lesions back in a very primary care setting, But when they go beyond this with a cavitation into the dentin, into the pulp, then we're limited that they need to be seen by a dentist, by a pediatric dentist, and tertiary care perhaps in those setups, like in these situations like this one. So it is essential that you know that we can reverse these lesions back if we see them early on. We don't want to ever to have a child to see them with these conditions. It's an issue of human rights and really an issue of equity. We cannot allow these children to go through life with this condition ever again. We teach the parents and the community workers to flip the lips. Head Start and Early Head Start and WIC are great alliances for us. We work with them to teach them to flip the lip and check for any of these white spot lesions early on. Step 5, as you know, fluoride varnishes are very now in use and common. I like the Unidose, the ones that they have the applicator in there, which is we wipe and paint the tooth in there. It is very important that you follow a protocol of, starting with the lower teeth or from the back to the front, but you need to paint every single tooth in the mouth and repeat with the upper arch as well, the better pattern that works for you. Someone emailed me the other day, so I found one white spot lesion in tooth number E, which is the upper incisor, and it says, should I just varnish that tooth? I said, no, please varnish them all, because the chances are that most of the teeth might be prone to get this condition. And when in doubt, just follow the manufacturer's instructions. There are many manufacturers for varnishes. Whatever works best for you, use that. And this is one of our students. We have an infant oral care clinic here at UCLA that we run every Wednesday mornings, and we have our third-year dental students are learning how to deal with babies and infants, which we strongly believe can make a big difference about really training the future providers to be very comfortable with infant oral health and oral care. So moving along in the next slide, we give the parent the instructions about what to do. We then talk to the parents about if they are themselves, do they have dental care? Do they need to have any rinse? So we might recommend them to look into some antibacterial rinses for adults and adults only as well. Then the child is raised back into the caregiver's arms. They will stop crying immediately, almost like magic. You give them a toothbrush, play a song with them, and you make this a very nice bonding experience. The last step is on anticipatory guidance, and we need to summarize the findings for the families, because most of the work they do are going to do it at home in their own place and with their families themselves. We need to assess the issue of risk-based anticipatory guidance. This is where we can connect the dots based on the risk assessment tool that we did and the child's condition. We can then say, okay, for Johnny, and this is part of a collaborative work that we've done years ago, where we came up with this great form of self-management goals. It's all in pictures, because we understand that the level of understanding in write-up in our families, in some of them might be limited. So we do these pictures. Now we say there's two conditions, two things you can do for next visit. For example, the use of tap water or the use of a little smear of fluoride toothpaste every day from 0 to 10. How sure you think you can do it for us? And if they give me a 7, 8, 9, or 10, we stay with that. They give me a 2 or a 3, I know that they're not ready, so we move them to another condition, like diluting the juice with water, or trying to stop the bottle at night, or just give them choices. Most of the families really are very appreciative when we give them choices on how to do. I don't need to emphasize enough to you that fluoride is the best armamentarium we have in our arms. And question 4 will be, is it safe to drink tap water? What do you guys think? Why do we have to struggle with so many families about the use of tap water on a daily basis? Yes, so a lot of you say yes, some of you say sometimes. Yes, so that'll be interesting to discuss. So yes, we do promote tap water. A lot of our families, because they come from other countries, especially recent immigrants, they are very scared of tap water, and they do not know that tap water is very safe here in the U.S. So if they don't want to use tap water, we recommend Brita or we recommend them Per. We try to get them coupons or information about where they can get these filters, or just to boil the water mainly will be a great thing. But we need to really be advocates for fluoridated toothpaste and for tap water. Our families need to be exposed to tap water because that's another way that we'll be able to prevent some of the disease in the future. The very important issue of limiting carbohydrates, right? I mean, we try to emphasize the need to count calories, to count the sugar intake. You know, we don't want generations to have obese and children full of cavities as well. So we try to limit the total sugar intake. We like to make them understand about some of the foods, the content of sugars is just horrendous, especially some of those juices or what I call now the junk on a pouch, which are these pouches that they're squirting into this child's mouth all the time, which is horrendous. So we need to be aware of some of those things. A little bit on fluoride varnish application. Someone was asking the question of the use of fluoride varnish. So I put this slide. We have to use it 3 times in a 2-week period for remineralization of white spot lesions. This is a recommendation from SEPA in Sweden, in Europe, where they think that to start bombarding these kids right away. But you know, the more rational recommendation to apply 3 to 4 times a year, every 2 or 3 months, depending the child's risk, will be a good way to do it. For older children, again, for older children above 6 and 7 years, when they can rinse and they can spit, maybe we can consider some rinses as well. We all discuss about the need to implement xylitol into our daily routine. Xylitol is a sugar substitute that is natural. It's found in vegetables and fruits. And a lot of the parents, you'll be surprised, they have no idea or awareness how to get them, how to find them. I'm trying now to stay away from the gum. The gum is something that I'm not really a proponent for, because a lot of the women or the parents came back with some problems with their jaws. They've been chewing too much, because you need to have 5 to 10 grams per day for the xylitol to make any good effect. So now I'm more inclined into products in gels, in lozenges, and in sprays. So that's some of the studies that are very, very much there in Finland and in Scandinavia, and also that they really showed that how we lower the levels of strep mutans and caries in these children. These are some of the products that I was telling you about, that is the spray or the gels that are out there, but it's something that we need to think about into the future. The whole idea that I want to make sure I leave you with as well today is that we can and we do remineralize these white spot lesions. The sooner we find them, and when we engage the parents, because we can do part of the job in our office ourselves, but most of the work the parents have to do it at home, and it has to be built in a combination therapy approach of things that you can do in the office with me, with fluoride varnishes and other things, what the mother can do at home for the baby themselves, and especially what the mother can do for herself, especially if she's the one spending more than 8 hours a day with the babies. When the enamel already is affected and you know, there's already that tooth is already affected, we need also to think about preventive. We cannot perhaps do stainless steel crowns or pulpotomies right on the effect. So there's some protocols that we wrote very nicely. I partnered with Dr. Manwei Eng from Harvard Children's Hospital and our camera group here, which are we built into these specific recommendations based on age and based on risk, and what are the kinds of things that you can do in those 3 levels: in the office, at home, and for the caregiver themselves. So please check them out. Tips for providing anticipatory guidance. We learn a lot from the families about what works, what doesn't work, and we need to really think about small steps. Choose 1 or 2 key messages. You know, we cannot expect them to change the whole world. Remain very positive. Always start very positive. You know, make them feel very alliance with you, that you know, that you are there with them, almost like a health coach that is going to help you to help them to move into this great engagement. It has to be culturally appropriate. We need to ensure and emphasize that culture plays a huge role about this condition. And some of the things that we learned through the years about you have to treat everyone with respect. Different people learn in different ways. Some people are visual, some people like to see what things you do. You can ask open and close-ended questions. I've learned through the years that we need to listen more. As providers, we tend to think that we have all the answers and we need to be the ones speaking. We need to listen, and I really practice and exercise to listen to my patients. So that's really a very important effort to do. We have to be very sensitive to their culture, their language, their race, their SES. And I think this is a hard one, non-judgmental. Try not to judge and try to be friendly. Small steps are great. Positive reinforcement is very good. So remember that little small steps, changes in health behavior do not happen over time, and we need small little things that will trigger this behavioral change. Make sure you document every single thing you do, especially if you're dealing with third-party payers. There are three main things that you need to have in any electronic chart record or any paper record that you have, and this is essential. If you get any audit or anyone is checking into your charts, you need to have at least that you have a risk assessment tool, regardless whatever it is. It doesn't have to be camera, but that you have some risk assessment tool that you practice on a regular basis with all your patients. Secondly, that you have some diagnostic codes or documentation of the diagnosis of how that child or those teeth to begin with. And the third thing, which is really important, is to document what messages or what summary of the visit you have engaged, and you demonstrate that you had some involvement of engaging the parents to leave them with some self-managed goals, so some very specific recommendations until your next visit. And the whole idea of referral and portability, especially if you are a non-dental provider, it's important that you refer these children early on, as soon as you can, at the first year or second year of life. So especially to have a good a dental home. We are striving for a good dental home. In some groups of children, especially with Head Start or migrant Head Start programs or Native American, the issue of Medicaid portability is essential, so we have to be very, very sensitive to convey and to send a message or their information to the next provider, especially if they're going to be moving back and forth from your area to another place. Someone asked me, and I'm trying to go through some of the questions because it's kind of hard to multitask here, but someone was asking about intermediate therapeutic restorations. Yes, they're essential. They are great armamentarium. We use them for minimal cavity preparation. Usually we try to use glass ionomers, which have a fluoride releasing material, which is such an essential part of our armamentarium now. You can learn more about some of these strategies as well. So we are very much strong advocates to seal, and we call it to seal of course the 6-year-old molars with whatever final restoration they have. But in very young children, my dream will be to seal the first and their second primary molars. Stay tuned. We don't have any evidence at all about this, but what we know, just for anecdotally with our patients, the sooner we start, especially in the areas that have white spot lesions or prone to disease, occlusal disease, we can certainly make a difference in the child's outcomes. So this is some of our glass ionomers we place by age 2 or 3, especially when they are already some enamel and decalcification as well of a cavity formation in the occlusal surfaces. So it's very, very important that you use this as part of the combination therapy approach. The whole idea of risk assessment is based on risk. You're going to maybe schedule Johnny to come every month to see you because he's extreme high risk, or you're going to see Mary every 3 months, or you're going to see Rosita every 6 months. So based on risk and age, you're going to then build up your risk assessment tool. The follow-up visits are essential. Remember, this is part of a disease prevention management model where we'll set up a tone to keep reinforcing the parents' good behaviors so they can be very much into a dental home concept that you'll be able to understand and convey and work with you almost like a health coach about things they need to do this. And reinforcing home care is our challenge. You know, a lot of providers tell me, but I tell them what to do, I tell them everything, and they don't pay attention, Dr. Ramos said. Maybe you should ask yourself, how are you doing that teaching or that education of the parents? We're learning so much with motivational interviewing, with parental engagement. I mean, there needs to be some sort of a rapport, and it's not an easy task. Sometimes you need to really be very sensitive and to really understand and to really meet them where they are at. Someone said that to me once, which was so essential. You know, we tend to think that we're there to tell them what to do, and we have no right to do that. We need to see where they are and really meet them where they are at and really put yourself in their shoes. It makes a huge difference. So in a nutshell, in a summary, we went through the 6 steps of infant oral health. I tried to summarize and review the AGDs. It's very, very important that we have different protocols based on risk for different children, based on low, medium, or high, or extreme high. So the whole idea and the purpose of the seminar today is to actually give you armamentarium and tools that you can really think about and work in a combination therapy approach for these children. I cannot leave you without really emphasizing about this wonderful addition to our team, which I think is essential. And we think that we might have a dental provider, a medical provider, as well as either hygienists, which are fantastic, as well as the dental assistants, which are really a treasure for us. But there is a link, there is a personnel there that with the years we've learned, call it case managers, health educators, promotoras, or patient navigators. We need to connect the families with the providers. And sometimes that role, it falls through because we don't have either the possibility of having some of these people in our team. But I really strongly recommend you to team up with WIC, with Early Head Start. Early Head Start has some great case managers. They have home visitors, as well as daycare providers in some states. They might have a home visitor as well, or a nurse. In the school systems, they have nurse connectors. So think about how you incorporate people in your community and build a team, because it really requires a village, and it's important that you have a team approach to these conditions for your program. Promoting infant oral care is an essential part of our daily lives, so I encourage you to think about too is too late. We need to bring these children very early on to us, and it's essential that we create this whole notion that we can have cavities-free generations. We have a choice, my good friends, today. Thank you for being with me, to have children like this or like this. We do have a choice these days, and it's essential that we help the parents to address this specific issue. And with that, I'm going to look at some of the additional resources that I want to leave you with. We have a wonderful training program here at UCLA, so you can go to our website. We have some of these training specific detail at uclachatpd.org. We have our wonderful and amazing resource with the American Academy of Pediatric Dentistry. We have our reference manual and every of these statements and policy recommendations through the AAPD.org. And as well with our amazing partner with the American Academy of Pediatrics as well. And North Carolina in the University of Michigan have this great program of baby oral health program, the BOHAP program, which I strongly recommend you that you check, as well as the prenataloralhealth.org, which is an essential also for pregnant women. And they'll have great tools, great resources available for you to download. And lastly is what we show you a little bit, just a teaser, on the 2 minutes twice a day that you should check on it. It's an amazing resource, and we're so happy and so excited we have that in our armamentarium to help our families to go through this whole notion of, first of all, the value of good oral health, and that we can have cavity-free generations. So with that, I'm going to try to see, we've got so many questions, and I'm not sure how we're going to be able to handle this at all, but let me see if I can go some of them. How early can you instruct parents to use MI paste on their children's teeth? So someone is asking more about combination therapy. I didn't really have the time to go through all the armamentarium, but we do have different and available different combinations. If you go through the article on Into the Future, Keeping Healthy Teeth Healthier, you have a whole set of protocols there. But briefly, let me tell you, we use combination therapy from the use of regular fluoridated toothpaste to rub it in those white spot lesions at night and put the baby to sleep then, just a small amount, just to leave it there, almost use it like a medication, we tell the mother. Then also we can use some other products as well as the 5,000 part per million, gel cam and other products that are like that, we can also can be very, very effective in their daily basis, especially for high-risk kids. And we need to have a combination of phosphate, fluoride, and calcium. That's what all the experts said, in some form, shape, or way. And again, in these kids, because we don't have any evidence, and it's just anecdotally, what I can share with you is that depending the risk, we try to do different of these combinations. But more in detail, and I don't want to get too specific, but you can actually check the article, and in the website, they will tell you about different combinations that we're using very effectively. Will be prudent action for companies who sell bottled water to include an effective level of fluoride ingredient? Absolutely. We need to advocate for the use of tap water with fluoride in it. It hurts me so much, all these families that they go and they have to fill out their containers in some of these grocery shops. We need to advocate for fluoridated water in these containers in our communities. Fluoridation, water fluoridation is one of the most effective public health programs in the country and in the world. And if anything, we are really, in some states here in the U.S. and some counties, we are very vulnerable for some anti-fluoride groups that they come against fluoride in the water. So it's a constant struggle, a constant battle. They do not understand the burden of disease that exists and how we have been able to really help these families and these children with the use of tap water. So it's essential that we all become advocates for water fluoridation, absolutely. And let's see, is there an age that fluoride varnish will be too early to use? A very good question. Well, fluoride varnishes I recommend as soon as the first teeth are in the mouth, especially in high-risk children. I will say it would be good to start them at baseline, as soon as the first teeth are there, especially the upper and three incisors, especially the siblings have had history of restorations of a lot of tooth decay, or the family is still breastfeeding, or you have all of those risk factors. Again, you need to really look and use your common sense to see what will work for that child, for that family, and for that age at that specific given visit. That's part of the beauty of the risk assessment tool that will help you formulate some ideas, the kinds of things that you can do for them. Well, we go on and on about remineralization. I'm so glad that you're so excited about remineralization. Someone asked how we can remove white spots. Yeah, you cannot remove white spots. You can remineralize white spots. Very good question. People think that white spots, if are treated, are going to disappear or removed. You cannot remove them, or they don't disappear. White spots are like scars. What they can do is make them from active white spot lesion to inactive white spot lesion. And that's what we need. We need to really teach in our eyes. And I know there's some protocols now by ICDAS, and there's new group of an international classification of management of these lesions that you can check online and look at it. But they really, really teach you how to train your eyes to look between an active white spot lesion or an inactive white spot lesion. That's very, very important. When you see that it's shiny and it's not dull and it's not chalky, you know that some of your efforts are being taken place, and but the white spot will still remain in there. Not as bad as if it's active. What else? What specific early interventions do you recommend? Again, at an early age? Well, I think it has to be a team approach. One of the things that we need to really think about is this team approach between medical and dental. Our future is going to be interprofessional collaboration and education. We need to integrate oral health into primary care. It's going to be essential that we create a team, regardless where you are, in Mexico, Brazil, the US, India, China, wherever you are. Try to build a team with other providers, especially where they see young children at a very young age, daycare centers, WIC centers, wherever these young babies are. You need to go to them and bring them over to you in a primary care setting. Work with your pediatrician, with your family physician, with your nurse practitioner, whoever is in your community, to build this team approach for early identification, early risk assessment, and early intervention will be essential and will make a huge difference in the family and this child's life. And I guess with that, I think our time is approaching. I have so many questions. You guys have been amazing. Thank you so much for your wonderful, wonderful involvement today. And we really look forward to stay in touch and maybe continue some of these forum series through Colgate. Thank you to Colgate and their whole team that they were so supportive to get this done. And I really appreciate you being with me this evening. Thank you so much.
Thank you very much, Dr. Ramos-Gomez, for sharing your lecture and your insightful information with us. We'd also like to thank Colgate for making this online course possible, and thank you, our wonderful audience, for your interest and participation. The CE quiz is now available online on the course page, and completing it will allow you to earn your ADA CERP CE credits. The recording will be posted online within the next 48 hours. You'll receive an email notification with a link to the recording. Further questions for Dr. Ramos-Gomez may be submitted directly on the website on the courses page under the Ask the Expert tab. So please go ahead and submit your questions, and Dr. Ramos-Gomez will be sure to get back to you as soon as possible. Please be sure to visit the Colgate educational platform www.colgateoralhealthnetwork.com and keep an eye out for our growing schedule of online courses. Thank you again to all. Take care and goodbye.